So now we're on chapter 13, mental health disorders. In this section, we'll get into the various mental health disorders, but it'll be more generalized. Going through everything in detail will take a very, very long time. So if you're pursuing a career in mental health counseling or a similar field, you'll get much more into detail with this during your training. First, we'll define what a mental health disorder is. So, first and foremost, it's a dysfunction in your thinking or your cognition, emotions, and or social behavior that impairs your functioning and is not culturally expected. So, it usually has to do these three things. It must violate social and cultural norms of how people are supposed to behave. So, the violation of cultural norms does not mean that being the quote unquote black sheep in your family or living life in a way that goes against societal or cultural expectations is a disorder, such as having children or not having children. What we are looking for is someone who isn't leaving their house. Or something a colleague of mine ran into was an individual who thought that when they turned into a certain age, they would become God. These are not usual ways of behaving or thinking. The other thing a mental health disorder does is it causes personal distress to the individual or those around them. So this distress caused in a person usually appears in an emotional or physical sense where they might have such heightened anxiety they are getting heart palpitations. The distress caused to other people is usually because someone is responding in a way that is hurtful, frequently inconvenient, or they are now requiring so much care because they're unable to be accountable and responsible at the moment. And then lastly, it creates dysfunction, or it interferes with a person's ability to function in everyday life. So the dysfunction needs to be seen impacting social functioning, work or school functioning, and personal functioning. So the person who isn't able to leave their house due to a phobia might become isolated. They might start getting written up at work because of how many days they're missing. And maybe they aren't eating or taking care of their hygiene because they struggle to go out to the grocery store. One term to know, though, is called psychopathology. So that's the scientific study of mental health disorders. And it's important to know you can actually have multiple mental health disorders at once. So each mental health disorder does have a specific criteria you need to meet. So in addition to the areas of functioning we talked about that need to be impacted, there's also a set of symptoms and a specific duration or amount of time those symptoms need to be present for, and those symptoms cannot be attributed to anything else. So mental health disorders are actually more prevalent than people realize, and our society has a high rate of anxiety and depression due to how our American culture at least operates. And with mental health disorders, they're actually a leading cause of disability worldwide. I've had plenty of clients I've had to fill out disability paperwork for because of a severe mental health disorder, such as bipolar disorder. So, females are more likely to have both any mental health disorder and a serious mental health disorder. When we say serious mental health disorder, usually we're talking about things like schizophrenia or bipolar disorder. Obviously, all mental health disorders are serious, though. Some are just more serious in symptomology than others. And then teens are 22% more likely to experience a mental health disorder with severe impairment or distress. Teens are exposed to a lot during crucial developmental periods, so they're more susceptible. I see a lot of teens with trauma, anxiety, depression, and eating disorders based off the pressure they face for school, social activities, and whatever is going on in their home life. But if something runs in the family, then stress they experience can trigger that disorder. And we also have healthcare workers. They're more susceptible to anxiety, depression, and secondhand trauma. Healthcare workers hear and see a lot of traumatic and negative things. And after so much time of being exposed to the trauma, disorders and concerns of others, they can start to experience symptoms related to anxiety, depression, and even secondhand PTSD. Now we'll look at some of the psychological theories that explain mental health disorders. First, we have the medical model. So that says mental health disorders are like physical diseases. They result from biological disturbances that can be diagnosed, treated, and cured just like a physical illness. This model is seen a lot with psychiatrists and medical doctors, but recent training has been incorporating other perspectives to assist with those providers being more well-versed and well-rounded when it comes to mental health. But it's definitely important to get checked out by your doctor because sometimes clients come in and they are having heart palpitations, anxiety, and dizziness, but it's actually related to POTS, as an example. Usually, this model looks at hormonal imbalances, issues with neurotransmitters, and our brain and bodily dysfunctions. Another model is the psychoanalytic perspective. So this attributes mental health disorders to unresolved, unconscious conflict. This looks at how conflicts from the past implicate the present, which a lot of the time is something we are not fully aware of. And it looks at conflicts between instinctive desires and our present reality. Psychodynamic theory, which stems from Freud, is in this bucket. So for example, we might look at how unmet needs from childhood impact your present and how you're unconsciously and maladaptively or negatively seeking out those needs in other people or other relationships. We also have the social learning perspective. This attributes difficulty in functioning to learning process such as classical conditioning, operant conditioning, and observational learning. With social learning, we're looking at how people have had positive or negative experiences with their learning processes and how that's impacted their behaviors. For example, if you spill or drop something as a child and your caregiver responds by yelling and demeaning you, you might be conditioned to learn that any mistakes warrants harsh outcomes, and as an adult, you respond the same way to your children, or you develop symptoms related to anxiety and depression because of the large amounts of pressure you're placing on yourself to now be perfect. We also have the cognitive perspective. This emphasizes thoughts, expectations, assumptions, and other mental processes in mental health disorders. So this one looks at how all these cognitions impact your functioning. So something we hear about the most is negative self-talk, and that can show up in a bunch of different ways. We also have the humanistic perspective. So this will consider mental health disorders as a result from a distorted perception of the self and the reality. We're looking at how we are unable to self-actualize or reach our full potential, and then we engage in maladaptive behaviors. So maybe someone has very low self-esteem and they may self-sabotage because they believe they're unworthy of something, or they do not believe in their capabilities enough that they are unable to attain certain goals to reach their full potential. The socio-cultural models focus on contextual situations and conditions that can lead people to unhealthy psychological functioning. So we're looking at how gender, race, society, and socioeconomic status, discrimination, and so forth play a role in your mental health. You'll experience things in society that inevitably have an impact, and I have a lot of clients who, rightfully so, are impacted by a variety of things, and it can cause social anxiety symptoms. And then we have the biopsychosocial model. So this integrates all and considers the simultaneous effects of many influences. This model is typically nowadays what we want to utilize because it incorporates all the perspectives. So you're not missing something, hopefully. If someone is living with an eating disorder, you use the medical model to see if they have medical conditions that could be impacting their ability to eat. The psychoanalytic model could see how unresolved past experiences may be impacting their eating. The social learning model perspective can see what they learned about food and body image. Cognitive perspectives would shed light on their internal thought process that's exacerbating this disorder. The humanistic perspective looks at how all of this has distorted the person's concept of themselves and their reality. The social-cultural model will look at how their environment enables or exacerbates the disorder, and so forth. So there's a lot more that will go into this, but this is actually the gist of it all. So now we'll look at the structure of the DSM, or the Diagnostic Statistical Manual, which is what we use to diagnose mental health disorders. It's presently in the 5th edition, but there's probably going to be another edition coming soon at some point. And it lists the diagnostic criteria for almost 300 mental health disorders in children, adolescents, and adults. So depending on which age category you fall into, the criteria to meet a specific diagnosis will differ. It also lists 20 major categories of mental health disorders. It does not tell you how to treat the disorders. And then it has a theoretical approach which underscores the complex biopsychosocial nature and the causes of mental illness. For the sake of time, there are a lot of disorders listed in this manual, and Table 13.1 in the chapter lists the major categories and some, but not all of the disorders, so that'll be something to look at. One thing that gets asked a lot is how good is the DSM model? And the reliability and validity for many of the diagnostic categories have improved over time. The thing though is with the DSM, it doesn't guarantee accurate diagnosis. Usually what you're relying on is the client's accurate report and the provider's assessment. So diagnosis usually involves subjectivity and personal bias, so sometimes people actually do get misdiagnosed, or it can take a long time to get a diagnosis. And symptoms may be listed as part of several disorders, so you kind of have to assess for a while and weed out which one it actually is. There's also some negative effects that come with labeling because they may serve as a self-fulfilling prophecy and create a social stigma. And a lot of assessing, as we see, needs to be done for all of this. So someone might present with symptoms of emotional regulation difficulties, impulse control issues, trouble sleeping, and disorganization. Generally speaking, you can find these symptoms in ADHD and bipolar disorder, so a lot more assessing would need to occur. But what can happen is I usually see clients with ADHD and I see them on a consistent basis for about a year or two and they want to try medication. So maybe they'll go see a psychiatrist who meets them for the first time, and based on the psychiatrist's subjectivity and lack of time with the client, they sometimes believe the client's living with bipolar disorder when they're not, and they'll actually try to prescribe them a medication that is not needed. Other times, people can come in because they want a diagnosis to serve as an excuse for their behaviors and, rather than use it to understand themselves and generate growth. Now we'll start looking at anxiety, obsessive compulsive, and trauma-related disorders. We do have research that helps explain anxiety, obsessive compulsive, and trauma-related disorders. Some research is looking at biological factors like neurotransmitters and genetic factors, so like low levels of serotonin. There's also those specific brain areas that have been identified as showing abnormal structure or activity. So OCD, for example, shows variances in how much gray matter is present, which impacts executive functioning, emotional regulation, and sensory processing. It's also shown that anxiety and OCD-related disorders do run in families. We then can look at psychological factors, so the cognitive processes and how we learn. So how we learn to respond to something will greatly impact how we perceive it, which then impacts our ability to feel competent or helpless. Some individuals also misinterpret their physical sensations in response to emotions and mistake them for something really bad. We also have social cultural factors, so the influence of poverty, sex and gender, race and ethnicity, and other factors have a part to play. Usually, many individuals will develop some sort of anxiety due to experiences from how they identify or where they come from. Anxiety, obsessive compulsive, and trauma-related disorders do have common components. You look at cognition and there's things like rumination or worry or paranoia. Emotionally, you can have dread, panic, restlessness. Physically, there might be sweating, racing heart, muscle tension, and behaviorally, you could have aggression, or the fight, flight, freeze response gets activated. Anxiety itself has a variety of disorders underneath it. So we have things like separation anxiety, selective mutism, phobia, agoraphobia, social anxiety, generalized anxiety disorder, panic disorder and panic attack, substance/medication-induced anxiety, anxiety due to a medical condition, and trauma-related disorders. Anxiety disorders are actually one of the most common ones you'll come across, and they can be in response to so many things, but it's usually based on fear and worry or anxiety. So, clinically defined, fear is the emotional response to a real or perceived imminent threat, whereas anxiety is the anticipation of a future threat. Now we'll look at types of obsessive compulsive disorders. Clinically defined obsessions are recurrent and persistent thoughts, urges, or images that are intrusive or they're unwanted thoughts, whereas compulsions are repetitive behaviors or mental acts that are a driver to perform in response to an obsession. So, the common one we usually hear about is obsessive compulsive disorder or OCD. And you can have subtypes of OCD, so OCD related to germs, relationships, severe vomiting, and so forth. And interestingly enough, you can actually have OCD and you can have obsessions without the compulsions. We also have body dysmorphic disorder, so that's usually seen in tandem with eating disorders because with this, you're not accurately perceiving how you physically look. And people will go to great lengths to adjust their physical appearance, whether it's plastic surgery, excessive exercising, or the development of an eating disorder. There's also hoarding, so people have hoarding tendencies, but it does not always mean they are a full-blown disorder. There's trichotillomania, which is hair pulling, and exorciation, which is skin picking. So the skin picking and hair pulling are a lot of times a coping mechanism that then turns into a disorder, and usually it gets paired with another disorder. And then, of course, we have substance or medication-induced OCD and related disorders, and OCD and related disorder due to another medical condition. So some people develop OCD regarding their cancer treatment and remission, but the symptoms are not present anywhere outside those aspects. Now we have types of trauma and stressor-related disorders. One of them is a reactive attachment disorder. So this is when a child will respond to their caregiver in a withdrawn way. They don't respond much to others, and it's usually because of insufficient care being provided. There's disinhibited social engagement disorder, and this usually occurs because of insufficient care, but you have a child who is consistently approaching strangers without any hesitation or awareness of the dangers that this could pose. There's also acute stress disorder. So this one's similar to PTSD, but the symptoms are present for 3 days to 1 month after the acute stressor occurred, whereas with PTSD, the symptoms must be present for 1 month or longer. So people will usually start off with a diagnosis of acute stress disorder and eventually move to a PTSD disorder. And then we have adjustment disorders. These are a very common diagnosis. They basically pose that individuals are struggling to adjust to an identifiable stressor within 3 months of the stressor occurring, and it doesn't last longer than 6 months. Because insurance requires a diagnosis to pay for sessions, a lot of clients will actually receive this diagnosis because it can account for everyday life concerns you might seek therapy for, like couples counseling, when you do not meet the criteria for another mental health disorder, nor do you need to be diagnosed with a disorder you don't have. Now we have dissociative somatic symptom disorders. So the first one we'll start with is dissociative disorders, which is basically this loss of self-awareness. So we're losing awareness of some part of ourself, our surroundings, or what's going on around us, and it's impacting our ability to function. And you might have mild dissociative experiences that are common in day-to-day life. One of these disorders is dissociative identity disorder. So this is the existence of 2 or more separate identities in the same individual, and each has its own unique personality. I met someone once who lived with this, and there's usually moments where they can't remember periods of their day, so there's some blackouts or amnesia that occurs. For example, this person I know went grocery shopping once and had no recollection of it because one of their alters, as it's called, did the shopping. Usually this disorder occurs when people experience trauma, and it differently alters how you respond to it. Some people come out of trauma without any harm. Some people come out with PTSD, and sometimes it can actually cause dissociative identity disorder. And usually what happens is that alter will come out during moments of stress. So in a way, it can be like a trauma response. We also have dissociative amnesia. So like we learned, amnesia is when there's difficulties remembering autobiographical information. And we also have another one called depersonalization/derealization disorder. Depersonalization is when you feel detached or like you are an outsider observing your thoughts, feelings, body, and so forth. This is not the same as mindfulness. Derealization is when you detach from your surroundings. In both instances, there are distortions to time and reality. Next, we have our somatic disorders. So the first one is somatic symptom disorder, and it's when physical symptoms occur without an identifiable physical cause, and there's usually excessive thoughts, feelings, or behaviors related to this. We then have illness anxiety disorder. So that's an ongoing worry and fear about having or developing a physical illness. This one was previously referred to as hypochondriasis or hypochondriac. This is the person you usually see going to the doctor all the time because they're so worried about every physical symptom they notice and they think they might be sick. There's also conversion disorder. So that's when someone has neurological symptoms like paralysis, abnormal motor movements, or issues with speech and swallowing, or seizures, and there's no medical explanation for it. Basically, there isn't anything found neurologically wrong. These sometimes also develop in response to trauma as a coping mechanism of sorts, or sometimes it develops as a way to seek attention. Usually something's going on where a mental health disorder is sometimes disrupting how your brain functions. Then we have facetious disorder. So a person intentionally and knowingly presents themselves as ill to others, and it's usually to warrant sympathy. Again, it's seen a lot with trauma, abuse, low self-esteem, relational concerns, and such. Now we'll go into depressive disorders and bipolar disorders. Now we'll look at the types of depressive disorders. One of them is disruptive mood dysregulation disorder, and this is a childhood-only disorder where there's temper outbursts and emotional regulation difficulties that are extremely out of proportion to the situation, and they're not on par with where the kid's at developmentally. We also have major depressive disorder. So with this disorder, individuals commonly present as sad, empty, irritable, and there's various somatic or bodily and cognitive changes. There's usually extended periods of intense sadness, hopelessness, and a lack of ability to take pleasure in previously enjoyed activities. Some physical symptoms you notice could be sleep patterns, appetite, and motor function changes, as well as fatigue and loss of energy. We also have cognitive symptoms, so the inability to concentrate, worthlessness or guilt, thoughts of suicide. There's an interesting fact about this disorder where you can have psychotic features, it can be seasonal, and you can also have anxiety with it or even catatonia, which is very unusual movements or behaviors, such as mutism or repetitive gestures. We also have persistent depressive disorder, otherwise known as dysthymia, and it's a less severe version of major depressive disorder, but it's longer lasting. So it's basically like a low-grade form of depression, but it needs to be present for at least 2 years, where major depressive disorder needs to be present for at least 2 weeks. So major depression will have very intense symptoms for short to long periods, while persistent depressive disorder will have less severe symptoms, but they're much more persistent, which can be equally as damaging, honestly. We also have premenstrual dysphoric disorder, or PMDD. So PMDD is like PMS, your premenstrual symptoms, but on steroids. A week or two before the period starts, some people will have the typical PMS symptoms like food cravings, fatigue, hypersomnia, insomnia, and so forth, but they're much more intense with PMDD to the point it impacts functioning. And then the mood changes you get are usually severe anxiety and depression to, again, it impacts your functioning. I do have some clients living with this, and when it comes around to their period, they're extremely different people. The joy and vibrancy in them is totally diminished, and they really struggle to keep up with their obligations. We also have substance/medication-induced depressive disorders, and then depressive disorders due to another medical condition. So these disorders also can generally be genetic, and certain experiences in life, like trauma, yet again, can trigger them. Now there's the different types of bipolar disorders. So there's bipolar 1 and bipolar 2 disorder, which are the more common ones we hear about. And I'll differentiate them, but first we'll start with that bipolar disorders are shifts in moods between two states, which are major depressive episodes and manic or hypomanic episodes. So major depressive episodes will resemble major depressive disorder, and they need to be at least 2 weeks in duration. Manic episodes usually last at least 7 days. And during this time, people have a super inflated self-esteem, a decreased need for sleep, racing thoughts, are easily distracted, excessive involvement in risky behaviors, an increase in goal-directed activity, and so forth. An example is I knew someone who had a manic episode and decided to climb a mountain in winter and almost froze to death. And another person who's a good example is sometimes you could tell they're having a manic episode because every time we had a virtual session, their living room furniture was rearranged and they were usually disheveled, talking a mile a minute, and had all the ideas of how to get rich quick and improve their life. Again, another person jumped out of a moving car during an episode. So these are usually what we call the different behaviors, and that's why I give these examples to show that mania is very severe and it can have dire consequences. It's not just having a lot of energy. Hypomania is similar to mania, but it doesn't last as long. It's usually around 3 to 4 days. So bipolar 1 disorder has the mania and bipolar 2 disorder has the hypomania, but both will have the depressive symptoms. And bipolar disorders can have a seasonal pattern to it. They can also have psychosis and so forth. They get very complicated, so they take a while to diagnose. We also have cyclothymic disorder, which is a less severe form of bipolar disorder, but it's more chronic. It's like the relationship between major depressive disorder and persistent depressive disorder. For cyclothymia, it needs to last at least 2 years, and the mania and depression do not meet the full criteria to be diagnosed as such. So you're basically meeting some of the criterion symptoms, but not all. And then we have substance/medication-induced bipolar disorder, or bipolar disorder related to another medical condition. And usually if someone has antidepressants with a bipolar disorder, it'll make it worse. So they end up needing to take mood stabilizers. And a lot of times medication's usually needed with these types of disorders. So there's some biological factors we look at when it comes to depressive and bipolar disorders. One of them is, again, neurotransmitters. So you're looking at malfunctioning neurotransmitters: serotonin, norepinephrine, dopamine, glutamate. There's low levels of serotonin and norepinephrine in depression, but also norepinephrine, dopamine, and glutamate are being looked into regarding bipolar disorders. There's brain structures, so abnormalities linked to depression, such as abnormal functioning of the prefrontal cortex. As we know, stress can actually start to shrink parts of the brain over time, which can be linked to depression. We also have stress hormones, so hormones that regulate sleep, appetite, sexual desire, and pleasure. And symptoms of depression relate to these bodily functioning. So sometimes hormones are dysregulated, which can cause these concerns. And then we have genes, so depression and bipolar disorders do run in families. Like mentioned before, biological factors don't necessarily go away, so sometimes medication is usually needed in those cases, but if you can address these psychological factors, it can help to significantly reduce the symptoms. Psychological factors for depressive and bipolar disorders are early adverse life events. So this is a theory that suggests depression is linked to unresolved childhood issues. And a lot of times it'll result in self-blame, self-hatred, and other symptoms of depression. There's also learned helplessness, which involves the belief that you can't control the outcome of events or what's going to happen. So this is actually part of the external locus of control we've discussed. Many people will feel powerlessness and like there's nothing they can do that will cause any sort of change whatsoever. But this can take shape differently, where some people learn that they're incapable of doing small tasks and they might require others to do those tasks for them all the time when they actually are capable of doing those things. And then there's also negative thinking. There is a boatload of different types of negative thinking, which you'll have a handout on that. But two of the common ones you see are the ruminative coping style, so it's focusing on how one feels without attempting to do anything about your feelings. And then there's cognitive distortions, so these are errors in your thinking. You're not really thinking based in reality. Now we'll look at schizophrenia spectrum and other psychotic disorders, and there's a few things we'll have to run down before we get fully into this. With these disorders, we are looking at delusions, hallucinations, disorganized thinking, abnormal motor behavior, and what we call negative symptoms. Clinically speaking, delusions are fixed beliefs that are not amenable to change, even though there is conflicting evidence. You can have persecutory delusions, so it's a belief you'll be harmed, harassed, and so forth by an individual, organization, or other group. There's referential delusions, which are beliefs that certain gestures, comments, environmental cues, and so forth are directed at you. Grandiose delusions are beliefs that you have exceptional abilities like wealth or fame. Erotomaniac delusions are falsely believing someone's in love with you. And nihilistic delusions are these convictions that a major catastrophe will occur. While there's somatic delusions, so it's preoccupations regarding health and organ functions. As for hallucinations, they're perceptions that are like experiences that occur without an external stimulus. So they're usually vivid and clear with the full force and impact of a normal perception, but they're not under your voluntary control. So these can be auditory, visual, or olfactory, so smell, tactile, feeling, and gustatory, which is taste. We also have disorganized thinking. So it's when someone derails from one topic to the next, answers questions with responses that are completely unrelated to the question or very loosely related. And there's what we call word salad, which is when the speech is so severely disorganized, it's incoherent and makes no sense. Usually that's someone speaking in vague symbolic terms, or they're not even finishing their sentences. And then we have abnormal motor behavior, and that's associated with catatonic behavior, so decreased reactivity to the environment. And someone may be mute and in a stupor, essentially. So some individuals have large grand gestures, like waving their arms without any observable reason, or there's individuals who will sometimes sit in a position without moving for hours. And then lastly is negative symptoms. These are associated with diminished emotional and facial expressions. People are very flat. There's a decreased ability to experience pleasure, which we call anhedonia. And there's asociality, or this lack of interest in social interactions and so forth. Now, when it comes to these types of disorders, they typically appear in late teens and early adulthood years. And the onset is typically somewhat later in women than it usually is in men. And usually it's diagnosed more in African American and Asian American individuals. And a lot of people with this condition can receive effective treatments that significantly reduce symptoms and improve their overall functioning. So if you get diagnosed with one of these or know someone diagnosed with one of these, it doesn't mean that you can't have a full life. Usually, though, early intervention is key. So as the theme's been, there's a type of schizophrenic and psychotic disorders, and a lot of them seem very similar, so bear with me. We have delusional disorder. That is one or more delusions within a month or longer, and sometimes there's mania or depression, but it's super brief. We have brief psychotic disorder. So you'll have delusions, hallucinations, disorganized speech, or the disorganized behaviors, or sometimes a combo of these. And it only lasts at least one day, but no longer than a month. Then you have schizophrenia. So you have to have delusions, hallucinations, or disorganized speech, at least one of these. And then there could be disorganized behavior or negative symptoms. But altogether, you need to exhibit at least two of these symptoms. Symptoms need to be present and persist for 6 months. One of those months needs to be the fact that the symptoms present for a significant portion of that time. It can't be sporadic symptoms or they only occurred once. We're looking for symptoms to be occurring every day, every other day, or 3 to 4 days a week. Then there's what we call schizophreniform disorder. It's actually very similar to schizophrenia, but the duration is just shorter. The symptoms will last at least 1 month, but no more than 6 months. And you have to have delusions, hallucinations, or disorganized speech. And then there could be disorganized behaviors and negative symptoms, but altogether, again, you just gotta exhibit 2. Schizoaffective disorder is where you have a major mood episode, so like depression or mania, for an uninterrupted period of time, along with delusions, hallucinations, or disorganized speech, just one of those. And then you could maybe have that disorganized behavior or negative symptoms. And then we also have a substance medication-induced psychotic disorder. So whatever's happening is getting induced by substance or medication, or the psychotic disorder due to another medical condition. Maybe a medical condition is actually what's causing this. There are high genetic factors associated with all of this. So onset, like we said, is around adolescence, early adulthood, and sometimes as well as people's 30s. Gender differences relate to hormones, can be a contributing factor to your onset, and episodes can decrease with age, but nobody's certain as to why. That's not necessarily the case for everyone, though. And recovery is related to care and social factors a lot of the times. And it can be genetic, but it's unlikely there's a single gene responsible for the disorder. If it were, the heritability rates would be a lot higher. So I've actually had a few clients with psychotic and schizophrenic disorders. One client ended up getting diagnosed with schizophrenia by me, and thankfully it was caught early on, but they're experiencing hallucinations of people who weren't there, feeling like they're being watched to the point they wouldn't leave their space. And as time went on, their facial expressions and emotional expressions became really flat and blunted, and so many other symptoms began to unfold. And like bipolar disorder, medication is usually needed for these disorders. Now we have personality disorders. The thing with personality disorders is that they are an enduring pattern of inner experience and behavior that deviates quite a bit from expectations of culture. It's very pervasive, they're not flexible, and the onset of these disorders is usually adolescence or early adulthood when a lot of your personality starts to develop. It tends to be stable over time, and it will lead to distress or impairment. So these can be something people could be born with, but we also see them develop, again, in response to trauma. And it's important to know this because someone could exhibit certain symptoms for a period, but it might not be pervasive and stable over time. So they wouldn't necessarily meet the criteria for such a disorder. It could be the symptoms are attributed to something else entirely. I say this because a lot of people very easily label others with personality disorders and they'll wildly misuse and weaponize these without really realizing what constitutes having such a disorder. Personality disorders are broken down into clusters. We have cluster A, which is odd or eccentric. And that one we have paranoid personality disorder. So that's someone who's excessively suspicious and mistrustful, believing others are malevolent. There's schizoid personality disorder, so it's a pattern of detachment from social relationships and a very, very restricted range of emotional expressions that can appear cold. And then there's schizotypal, which is like a very, very, very mild schizophrenia, but usually you'll see extreme discomfort in close relationships, cognitive or perceptual distortions, and very just eccentric behavior. Now we have cluster B, which is dramatic, emotional, erratic. The first one is antisocial personality disorder. So that's the disregard for and violation of the rights of others. There's a lack of remorse. This used to be psychopathy or sociopathy, but not everyone who lives with this disorder turns into a serial killer. It's very rare. We also have borderline personality disorder. That's marked by extremely unstable relationships, mood, self-concept, and high impulsivity. Then we have histrionic, which is excessive emotions and attention seeking, and narcissistic, which is grandiosity. So it's an inflated sense of self. There's a need for admiration and a lack of empathy, and they'll view themselves above others. Everyone is calling everyone a narcissist nowadays, which is unfortunate because the term is being widely misused and weaponized against individuals who may appear to fall in this disorder, but actually don't. And then we have cluster C, which is anxious and fearful. So you'll have avoidant personality disorder. That's social inhibition, feeling of inadequacy, and hypersensitivity to negative evaluation. There is dependent personality disorder, so you're submissive and clinging to people, and there's an excessive need to be taken care of. And there's actually obsessive compulsive personality disorder. This isn't OCD at all, it's just preoccupation with orderliness, perfectionism, and control. I've had a lot of clients with various personality disorders, and it's interesting because you'll notice that a lot of this dysfunction is generated from a very distorted perception of their self-image and identity, which we know is a large component of our personality. In therapy, though, a lot of boundaries need to be set. And you can have personality disorders related to medical conditions. So last we have feeding and eating disorders, addiction, neurodevelopmental disorders, and gender dysphoria. So feeding and eating disorders and addictions were covered in a previous lecture, but just to go over it briefly is that a lot of those ones will include different types of addiction and withdrawal. And then with the feeding and eating disorders, there's anorexia, binge eating, bulimia, pica, eating non-food substances, rumination, so you regurgitate food and sometimes rechew it, and avoidant restrictive food intake. For neurodevelopmental disorders, some common ones we'll see are autism and ADHD, which they impact your brain development. So with autism, you'll see communication and socialization are greatly impacted. You'll notice social cues are missed, eye contact's difficult to make, relationships can be difficult to maintain and understand. There's issues with back and forth conversation, structures have to be adhered to, fixated interests are common, and so forth. It's on a spectrum, so some individuals are what we call low functioning, mid functioning, and high functioning. And what this means is that based on the severity of symptoms, you may be severely, moderately, or mildly impaired. As for ADHD, the DSM states you can have predominantly hyperactive, so fidgeting, difficulty waiting your turn to speak, racing thoughts, issues with impulse control, or predominantly inattentive, so difficulty sustaining attention, paying close attention to detail, following through with tasks, organization, avoiding tasks requiring a lot of mental attention, and so forth, or a mix. Now, there is someone called Dr. Amen who poses ADHD can actually have 7 different types. So classic, inattentive, over-focus / difficulty shifting attention from task to task and managing time. There's temporal lobe, which is increased irritability, anger, paranoia. Limbic, which is classic ADHD with sadness, negativity, and low self-esteem. One's called Ring of Fire, which is just extreme irritability. Anxious, so anxiety, tension, stress, and worry. And then with gender dysphoria, that a lot of the times is just a discrepancy between how you physically present gender-wise and how you mentally identify. That can cause a lot of people quite a bit of distress. And that concludes our very brief coverage of mental health disorders.